Our topic today is stages of papilledema. Now, papilledema is nearly always bilateral, but may be asymmetrical. In early stages, mild disc hyperemia with preservation of the optic cup, indistinct peripapillary retinal nerve striations and disc margin. Spontaneous venous pulsation is absent in about 20% of the normal individuals and may be difficult to identify even when present. An identifiable venous pulsation is at least one eye means that ICP is normal at that point in time. Bearing in mind that diurnal fluctuations can occur. Now, the next stage is the established stage or acute stage. There is normal or reduced visual acuity, severe disc hyperemia, moderate elevation with indistinct margins and absence of physiological cup, venous engorgement, peripapillary flame-shaped hemorrhages, and frequently cotton wool spots. As swelling increases, the optic nerve head appears enlarged. Circumferential retinal folds or patent lines may develop, especially temporally. Macular fan in younger patients, small vesicles may appear in the superficial retina converging in the fovea, on the fovea in a shape with an apex at the fovea. This is not to be confused with the macular star, which is composed of exudates. Blind spot may be enlarged, and this can be seen on examination. The next stage is the atrophic or the chronic stage. Visual acuity is variable and the visual fields begin to constrict. Disc elevation without cotton wool spots and hemorrhages can occur. Here you can see all the stages. Patent lines are visible in this number C. Now, idiopathic intracranial hypertension, which is previously known as benign intracranial hypertension or pseudotumor cerebri, is characterized by elevated ICP that by definition has no identifiable cause. Obese young adult women are the most commonly affected group. Various medications, including the contraceptive pill, have been implicated. Strictly secondary intracranial hypertension if a cause is identified, as well as a range of conditions such as SLE, Lyme disease, and sleep apnea syndrome. Now we'll discuss the diagnosis, which is based on symptoms and signs and investigations. Symptoms and signs are similar to those of papilledema, with headache in over 90% of the cases. Pulsatile tinnitus may be experienced, and cranial nerve palsies and occasionally other symptoms may occur. The long-term visual prognosis is usually good, but up to a quarter will have a degree of permanent impairment. That is a huge 25%. Investigation is for papilledema. Optic nerve sheath diameter is increased, and MRI may show slit-like ventricles and flattening of the pituitary, which is empty Sella sign. MRV is usually carried out to exclude cerebral venous sinus thrombosis or stenosis. Additionally, investigations for an occult cause should be considered, especially in patients which do not fit the usual profile, especially women of not childbearing age and which are not obese. Now, the treatment, of course, first of all, weight loss, including via bariatric surgery, can be very effective, and formal dietary intervention is strongly recommended. Other options include acetazolamide, furosemide, digoxin, and analgesia, and in unresponsive cases, optic nerve fenestration. LP shunting and transverse dural sinus stenting. The use of steroids is controversial, but a short course and some time is sometimes used in severe papilledema. Intravenous mannitol or lumbar puncture is usually reserved for acute severe exacerbations. Now, the role of ophthalmologist is usually confined to diagnosis and monitoring of visual functions with visual acuity, color vision, and fields, optic nerve appearance, and photography. That's all.